Hi, everyone, and welcome to the American Ambulance EMS podcast. I'm Dr. Danielle Campaign, American Ambulance's medical director. I'm here with our fantastic co-hosts, Mr. Ben Wheatley, Dr. Sajjan Bhakta, and Dr. Patil Armenian.
Hi, everyone.
Hello.
Hello.
Today, we're going to be talking about spinal motion restriction. Please stay tuned. Later on in this podcast, Dr. Miranda Lewis, our SEMSA medical director, is going to be popping in and sharing her take on the new spinal motion restriction protocol also. So let's kick off this topic of today's podcast, spinal motion restriction, and why our Central California EMS agency is changing course on the use of C-collars. So Ben, why don't you give us the history?
Sure. So in the mid-2010s, our local LEMSA shifted away from routinely using backboards for trauma patients and went further by discontinuing cervical collars altogether. Instead, they adopted head blocks and tape for spinal immobilization. And this change was driven by evidence suggesting that the combined use of backboards and C-collars could negatively affect patient outcomes. Debates over spinal immobilization have long divided trauma care providers, with some favoring universal backboarding, others advocating for upright patient positioning, both supported by evidence. Recognizing the strong opinions on both sides, CCMSA just reviewed the latest trauma care data and, effective September 1st, will reinstitute cervical collars while continuing to limit the use of backboards. This balanced approach kind of prioritizes evidence-based decision-making to optimize patient outcomes.
Right, so let's go through the statistics. Patil.
In a 2023 study, patients on backboards spent an average of 54 to 77 minutes on a backboard following a traumatic event. So that includes 21 minutes on average in the hospital on a backboard. The goal with backboarding patients is to create, in effect, a cocoon that prevents motion, which may exacerbate existing injuries or create new ones. And if you've ever laid on a backboard during a training, you know how uncomfortable that position is. The C-collar adds a potential layer of discomfort, which kind of goes against the EMS provider's overall goal, which is to make their patient feel secure and comfortable en route to definitive care. Now, the same 2023 Canadian study highlighted an increase in using cervical collars alone for patient positioning on the gurney. This approach effectively maintains cervical spine alignment while avoiding the pressure points and potential additional trauma caused by backboard use.
Now, before we jump into the protocol, I just want to talk a little bit about backboard use. Sometimes you need a backboard to get a patient out or to extricate somebody. And so you may be using it for that. Or Ben, why don't you elaborate on sometimes you need that backboard. And I think on the selective backboard use, we're more talking about the elderly person who maybe ground level fall and doesn't need a backboard, but you just need to immobilize their neck.
Yeah, before all of these changes in the mid-2010s, I distinctly remember a call where an elderly woman had fallen days prior and was complaining of shoulder pain, but there was no way out of fully putting this woman in a backboard with a C-collar, laying her flat. And she was so uncomfortable. And I remember her crying, this hurts. And it was our protocol says that we have to do this. And so the backboard, has a long history of its uses, but it felt like we were overusing it. And then we went to going away from it altogether. It's a great tool. It's a great device for extrication. And certainly it has its use in spinal motion restriction. But we also need to weigh that against overall patient health. And so we're going to go through the criteria here, but there's some paramedic discretion about when we are going to use that backboard.
Right. I love paramedic discretion. Everybody goes through lots of training. And so not just being told you have to do this, like that case you were talking about. It's I have to. This poor woman put her in this when it's been, her fall was 3 days ago. Just remember the goal of spinal motion restriction, and this is written straight out of the SEMSA protocol, is to prevent secondary injury and worsening morbidity in patients with unstable spinal injuries. So reserve full spinal precaution use for high-risk patients and avoid complications associated with full spinal mobilization. So our goal is really to decrease and minimize use of backboards, but really still use them when it's high-risk injury. The high-speed MVC and someone who's got a neurodeficit, they're going to get everything. So let's go through it. Ben, you want to take us through this?
Spinal motion restriction, we're going to SMR, we're going to shorten it to SMR, aims to prevent further injury in patients with suspected spinal trauma by applying precautions selectively to high-risk individuals while avoiding complications from full immobilization. It really does prioritize patient safety without compromising airway, breathing, or circulation. SMR is indicated in blunt trauma patients with altered consciousness, intoxication impairing exam reliability, significant midline neck or back pain, focal neurological deficits, spinal deformity, or distracting injuries that hinder a reliable assessment. Clinical concern alone can warrant SMR application.
There are some contraindications and special considerations mentioned, so it should not be used in isolated penetrating trauma, uncontrolled facial or oral bleeding, or any hemorrhage that impairs the airway. Poorly fitting cervical collars can actually worsen injury, and alternative stabilization methods should be used in patients with anatomical deformities or size constraints from using the collar. So in those cases, you can go back to the blocks and tape method.
Yeah, and here at American Ambulance, we've elected to buy cervical collars that are adjustable. We'll have a couple different sizes that can each be adjusted. And so do your proper measurement. Measure the patient's neck, make sure that you have the right size collar.
In spinal immobilization, the procedure, it does not take precedent over airway and cardiovascular stabilization. So remember, A comes before the C-spine. And so we really want to make sure that we're not making this a priority, like, oh, we got to put you in a collar, even though it's going to make your airway worse. So assessment includes neurological exam and spinal palpation. Cervical collars are applied with inline stabilization. You're going to avoid traction or forced neutral positioning if pain or resistance occurs. Patients are secured supine with head, neck, and torso aligned using the device like the backboard or the vacuum mattresses with lateral head support when possible through use of a backboard is not required. Ben, do you want to kind of break that down a little bit on how we're teaching the procedure in patient handling?
It's kind of relying on the things we used to do. So, more than half our staff is new. And so I know we learn it in EMT school, we learn it in paramedic school, but it really is a team-based thing that we're doing. And so we shouldn't be applying these alone if at all possible. One of the providers should be holding the neck in an anatomically correct position. And the other person is going to work around my hands as I'm holding the patient's head to apply that cervical collar. C-collar size is really important. The previous iteration of this policy, we had, as I said, one size fits all kind of collars, and they weren't the best. Now we have multiple sizes, and each of those sizes can be adjusted according to the patient's anatomical structures. And so do a good assessment, make sure that you're measuring the size of the neck, and find the appropriate size collar to go on that neck. As you're applying the C-collar, don't manipulate the neck, don't twist the neck. We want to make sure that we're holding the patient's head in a neutral position. And then, as we're going to talk about, getting them onto a backboard or getting them onto the gurney is going to kind of be dependent on the patient's presentation. So a lot of the time, we're still going to ask the patient to just look ahead, go ahead and sit on the gurney, get into a comfortable position looking straight forward. And a lot of time that's how it's going to be. For, multi-systems trauma, we're getting them onto the backboard with a team. We're going to do the log roll, and we're going to roll them onto one side, check their back for any injuries, roll them back onto the backboard while holding the patient's neck with the C-collar on and securing them that way.
We are so fortunate today that Dr. Miranda Lewis, our SEMSA medical director, just popped into the studio. And so she's going to share with us her thoughts on spine immobilization.
So one of the things to emphasize is, you were talking about not manipulating the patient's neck and being careful that the collar fits appropriately. One consideration is that you don't want to pull traction on the spine. So oftentimes if the collar is ill-fitting, you're actually pulling up on the neck, and that can do harm. Another consideration is that there are going to be patients where cervical collars don't fit. So if you particularly think about geriatric patients who have really bad kyphosis or curvatures of their spine where they can't lay flat, those patients you may be doing more harm than good if you try to place them in a collar. So there are situations where, you can just appropriately pad the patient and not put the cervical collar on if it doesn't fit appropriately. So I just want to emphasize, while we are bringing the collars back, there will be situations where the collar may not appropriately fit a patient. So the best approach is going to be, applying padding around the neck and securing the neck in an alternative way.
So as you roll this out, we're doing education in our valley. Are you finding some questions or some parts of the protocol that people are really worried about? And if you could share those with us.
So one of the concerns that has come up is that we are going to be immobilizing every intoxicated patient that we come across. And that is certainly not the goal. So we really are saving immobilization for those patients who have altered mental status in the setting of blunt trauma. So sure, if you've got an intoxicated patient who has significant head trauma after a ground level fall, and they are so altered that they can't perceive pain appropriately or communicate their pain, then immobilize them. But don't immobilize every drunk person you come across. So that was one question that has come up a couple of times. So I just wanted to clarify that. The other is that we are really not aiming to apply spinal motion restriction to more patients. If anything, we should be applying it in fewer patients. And so if you look at the old protocol, we had an indication for immobilizing patients who had severe multisystem blunt trauma, just based on mechanism alone. And that is no longer the case. So we are not going to immobilize people only by mechanism. But if you have a blunt trauma mechanism in the setting of all of those indications that we already mentioned earlier.
I think that's a key point because it's kind of like you have to have the trauma first. If I'm walking around drunk and there's no suspected trauma, there's no reason to immobilize me. But if I have fallen down a ravine because I was drunk, then you should probably immobilize me because I'm not going to be able to perceive pain and protect my neck.
Exactly.
Great. Sajid, why don't you kick us off with pediatric considerations, and then we have some scenarios to go through.
So the spinal motion restriction approach is going to be very similar for pediatric patients with decisions based on clinical findings rather than age alone. Children may be secured in car seats or stabilized with alternative supports on the gurney if collars don't fit. Elevation of the head up to 30 degrees is permissible while maintaining alignment, but we want to try to avoid sitting or 90-degree positions, which are contraindicated if you are worried about cervical injury. And just to highlight that we may not need cervical precautions in all these patients, a 2022 review of nearly 3,000 pre-elementary trauma patients showed that imaging was not necessary for patients less than 5 years old without any clinical findings on exam. So again, following the protocol, you're going to be using your exam to really judge whether or not we want to be immobilizing the cervical spine in children, just like we're doing the same for adults. Especially in children where they're not going to be as cooperative, it may require you to abort using the spinal motion restriction. As long as you're documenting and talking to base, just make sure everyone's on board with what you're doing and what you're worried about.
Let's go through some scenarios and kind of talk about each scenario, and we'll have everyone weigh in. So first scenario, adult blunt trauma patient with altered mental status. So a 45-year-old male involved in a motor vehicle collision presents with a GCS of 13. They're confused, no reported neck pain or neurological deficits, but appears intoxicated. What do we do? Ben.
I'm going to say yes, this patient would need SMR indicated due to the level of consciousness and the alcohol the patient's consumed. So we're going to apply the C-collar and we'll stabilize on the gurney if the patient can follow directions. We could also use the backboard if we need to.
Right. And I'd say because of the setting of trauma, because it was a high-speed motor vehicle crash and they're altered, they're not able to tell you if their neck is really a problem. What do you think, Dr. Lewis?
I concur.
Perfect.
I think that's the best approach.
All right.
Okay, I'll do the next scenario. So this is a 30-year-old female with a single stab wound to the abdomen from an assault, alert and oriented, no spinal complaints, no neurological deficits, stable vital signs. What do you guys think?
We're going to pick on Ben, our paramedic.
I'm going to say no. This practice is contraindicated for isolated penetrating trauma. So no C-collar, no backboard.
That's right.
Awesome. Sajid, do scenario 3 for us.
The next scenario is back to our pediatric patients. So we have a 10-year-old child who fell from a playground structure complaining of midline neck tenderness, is alert with no neurologic deficits or altered mental status. What do we think we're going to do here?
I'm going to go with yes. SMR is indicated for pediatric complaint of neck pain in a traumatic setting. We want to apply appropriately sized C-collar or alternatives like towels, pillows. We're going to stabilize on the gurney or possibly in a car seat if we can get a car seat.
I just say most 10-year-olds hopefully aren't in car seats still, but if they need one.
A booster seat. Yeah, something. Yeah.
What do you think, Dr. Lewis?
Yeah, I think in this setting, you've got a mechanism that potentially could lead to cervical spine injury, and you've got neck tenderness, and those are indications for mobilization.
Perfect. Got another scenario for you. 55-year-old male after a fall from a height with a fractured femur causing severe pain, but no spinal tenderness, has a normal neurological exam and is fully alert. Ben, what would you do?
Yeah, I would put this patient in backboard, indicated because of the distracting injury and a fall from a significant height. We're going to put this patient on a backboard. That distracting injury can impair a reliable exam, which is in the name. It's a distracting injury. It hurts so bad that you're not even thinking about your neck maybe tweaked a little bit. We're going to apply the C-collar and we're going to stabilize on the backboard of the gurney.
Yeah, I think that's appropriate in this circumstance. That idea of a distracting injury is going to be a little bit up to the paramedic's judgment and to, whether they think that injury is inhibiting their ability to perceive any potential spinal injury. And I think in this case, with that severe, you may not be able to get a good assessment of the spine and concern for spinal cord injury.
And I want to highlight that, Dr. Lewis has really made all of these protocols part of paramedic judgment. And so I think it's a really neat and great way for the paramedic to use their discretion on scene and really use their knowledge, which in past protocols have been just very, do step 1, step 2. And I think there's going to be a learning curve with that. But I really want to highlight that as we've got if that paramedic is suspicious for any reason, put them in it.
Yep.
And the last scenario is a 35-year-old female involved in a low-speed rear-end collision, complaining only of low back pain, no neck issues, fully alert, no neurological deficits, and no distracting injuries.
Yeah, so for this patient, I would not put this patient in spinal motion restriction. I would obviously advise them to just, stay still on the gurney. We're going to get you over to the hospital, but I don't need to put this patient in a C-collar. It's lumbar pain. I'm just going to ask them to be mindful of any extra movement, and we're going to get you over to the hospital safely.
Great. So this was kind of our quick review of the new spinal motion restriction protocol that's going live September 1st, 2025. All right, Sajin, what's your take-home point?
This protocol is all about your clinical exam, so remember to use your exam and your judgment.
Ben.
Yeah, using the judgment as a paramedic in this system, it's kind of a new idea for us. Our protocols have always been kind of very like this, and this. So it's fun to have that kind of paramedic discretion. And in that paramedic discretion, you have a couple of options. You can, think, what's the worst case scenario here? Maybe the patients who kind of in between, should they get SMR? Go ahead and put them on the backboard. Or give base a call base and work through it with a physician or a nurse there, and they can kind of coach you through the best practice on it. So,
Patio.
I think it's just like we're reaching a nice happy medium with our protocols, because before it was so strict, right? Everybody gets backboard and collar, and then we went completely away. And now I think we're finally coming to the right place of you can use either, use your discretion, and I think that's always a good place to be.
Dr. Lewis.
I think just remembering that one size fits all is not going to work for cervical collars. So remembering that some patients, it might not fit appropriately. And so you might have to restrict the movement in an alternative way, especially for those geriatric patients who are at high risk for cervical injury.
Yeah, and then my take-home point is respect the distracting injury or respect the mechanism, because if it's like a football injury and they speared each other's heads, you would think, oh, how bad could that be? But we've seen a lot of injuries. So if you suspect the injury or you hear the story, please put them in a collar. Thanks, everyone.
Thank you.
Thank you.
thanks.